Hi, so here I am again. I think some of you probably maybe saw me yesterday, or maybe some didn't. Um, and so yeah, so this is a little interesting to do this a second time. I don't know how, probably similar, but not quite exactly the same. Can the screen be made brighter so I can see it?
Absolutely.
So yes, we had technological difficulties yesterday with the recording. I thought the talk went well, but we didn't have a recording to post, so it seemed a good idea to do it again. And then it turned out some people didn't see it yesterday. So anyway, this is my talk. This is who I am. This is my email, if anybody wants to email me. Conflicts of interest. Many of you know that I crowdfund my academic position at Berkeley through donations through Berkeley's crowdfunding platform. So I have been accused a lot of times of having, those are conflicts of interest. Certainly they're perceived conflicts of interest, and certainly, you know, it's understandable that people might think that they're conflicts of interest. So I guess in some sense, you know, they're conflicts of interest that I disclose. But in terms of whether I'm doing this work because I'm getting paid, or that I'm writing things I don't believe in because I'm getting paid by patients, I just wanted to point out that I did my first investigation of PACE of 15,000 words, which took like a year and a half to do, all on my own. And then I worked on this project for another year or two after that, on my own, with no support, just because I was interested, just because I could, and because it was a public service. And so I only started crowdfunding when my position at Berkeley changed and I needed to actually have income. And so I turned this into my project at the advice of the dean of the School of Public Health, who it suggested that I try to crowdfund my academic position, which seems very unusual, but that's what I've done. And so money goes, in contrast to what people have claimed, money goes directly to Berkeley. I don't see any of it. And they use that to pay my salary and benefits, which is mainly my health insurance. Okay, so that's that. Who am I? I'm older. I just turned 66 last week. So I graduated from college in 1978. I grew up in New York. I moved to San Francisco in 1988 to be a reporter at the San Francisco Chronicle. I've done a lot of work for the New York Times, although I never was on staff. I covered health a lot, mainly HIV and gay and lesbian issues, but gay health and HIV issues and health insurance in the 90s. And then I went to get my Master's of Public Health at Berkeley. And then I got my doctorate of Public Health at Berkeley, a DRPH. I don't know if that's in other countries, but it's Doctor of Public Health. And it's an interdisciplinary doctorate. So it's not a PhD. It's a bit more generic, and it's a bit more kind of interdisciplinary and also shorter. So maybe it's just somewhat different. And I started this project in October 2015 when I launched Trial by Error, my series. I just thought it was a one-off. It was a 15,000 word investigation of the PACE study, that piece of crap, as I've called it often. And I thought that would be a one-off because I assumed it would have to be retracted. Of course, it wasn't retracted, and it's still not. And so I just kept writing and writing and writing. And here I am. So I've written also as part of this, it's not just the blogging, I also write news articles for news organizations. I've written peer-reviewed publications, mainly commentaries, because I'm not really much of a researcher, or sort of much of an academic researcher. I do academic commentary more. I write a lot of irritating to the journals, not to me. I enjoy writing them, but I've just been engaged in a dispute with Bristol University. So I've been posting some of my kind of letters to them, and I'm on social media, obviously, and I do talks like this. So that's basically the whole, my project encompasses all of these things. It's kind of a quasi investigative journalism, investigative academic, investigative epidemiology. I don't know quite what I'd call it. So it's kind of a quasi mix of academics and reportage. So this was my initial foray into this domain. I was disturbed terribly by the PACE trial when I read it, when I read what patients were writing about it, and this is how I started my project. At this point, actually, 7 years ago this week, pretty much, or next week. So I hadn't realized, I'd forgotten that it was actually exactly 7 years ago. I never intended to continue it. I thought it was a one-off. I had other interests, but it just kept going because nothing was happening. So in this talk, I'm going to talk a little bit about, or something about, medically unexplained symptoms and chronic fatigue syndrome, as it has tended to be called previously, is sort of a classic, or the medically unexplained symptoms. This is a term which has been very popular in the last, I don't know, 20 years. It came out of the notion many years ago. In the 19th century, women were often, or some men, but more women, were often diagnosed with hysteria when they had symptoms that couldn't be explained. Freud sort of termed it conversion disorder. Those are sort of archaic things that don't tend to be used, although you still see conversion disorder is still in the DSM-5, the psychiatric manual, although it's been sort of replaced by functional neurological disorder, which is another kind of word for MUS. So medically unexplained symptoms gets shortened to MUS. So you're looking on PubMed, a database, and you can find a lot of studies about MUS. It's also called somatic symptom disorder, somatization disorder, persistent physical symptoms, bodily distress disorder. As I said, functional neurological disorder is a growing category, or I mean, a category that's used increasingly. I wouldn't say I wouldn't say it's a growing category in terms of more people, but it's become many people now with long COVID or with chronic fatigue syndrome are getting diagnosed or given diagnoses of FND, functional neurological disorder. Maybe previously they would have been given medically unexplained symptoms. So there's sort of some interchange. And many people, it's considered really hypochondriasis. These people are considered hypochondriacs, and that's been changed more recently to the term health anxiety, which I think is probably perceived as less not defamatory, but less insulting than calling somebody a hypochondriac. So the examples that are classically used are chronic fatigue syndrome, irritable bowel syndrome, fibromyalgia, other things like multiple chemical sensitivities. Basically, it's anything that can't be figured out biomedically. And the problem with the term, the medically unexplained symptoms is a term that's neutral on its face. It just means symptoms that aren't explained. Unfortunately, there's a linguistic sleight of hand that occurs, and what people really mean when they say it is usually medically unexplainable in perpetuity symptoms. In other words, we've decided that these symptoms can't be explained by standard organic processes or pathophysiological processes, so something else is going on. What else is going on in the minds of those who are using this terminology generally is some psychological, these are anxiety-related disorders, depression-related disorders. People are somehow psychosomatic disorders, psychogenic disorders. So psychogenic is another word for psychosomatic. Psychosomatic is another word for medically unexplained symptoms, essentially. These terms all have somewhat different meanings. I mean, you can find different definitions, so they're not 100% overlaying on each other, but they all share these kind of common characteristics. And they're all essentially interchangeable, even if there were technically somewhat different definitions for each. The idea is that once you've given this diagnosis, then more medical tests are just unnecessary and not even harmful, because they encourage patients to falsely believe that there's a biomedical explanation for their symptoms, as opposed to a psychological or a behavioral one. And so patients given this kind of diagnosis can often wait years if they want to pursue another diagnosis. It may take years to get a proper diagnosis, or they may never get one. Maybe maybe some things are just really hard to explain with our current understanding. The people who use this term as if it's medically unexplainable seem to believe that progress has stopped at a certain point, and so now we know everything, and so if they can't explain it, it's unexplainable forever. So this is a kind of a problem. When we talk about epidemiologic obfuscation, MUS does present difficulties to investigators, both in clinical trials and in observational studies. So those are the different kinds of research: clinical trials or experimental trials, and observational studies where you sort of observe what's going on, but you're not actually putting people in different groups. You're just observing where they are. The difficulties of this is that these conditions all lack definitive biomarkers, blood tests or other kinds of medical tests that will allow you to pretty precisely identify who the patients are. What happens when you have conditions that are defined essentially by symptoms? There are tests, basically with all of these things, there are tests that you can do that point out certain aspects, but In no cases have there been approved tests that are agreed upon as standard tests that identified the people. And that creates disputes over the etiology. Are these psychological or biomedical disorders? Now, many people who promote these ideals will say, oh, that's just that false mind-body duality, and it's bogus, and we can't divide the mind and body. And of course, that's essentially true. The problem is we don't say that if someone has a heart attack. We don't say, oh, they're confusing mind-body. We say, let's deal with the heart problem. Just because we can't find what the problem is doesn't mean it's sort of this in-between gray area. It might be, but it might actually be a biomedical problem that we just don't understand. As I've suggested, this means that it can be hard to find objective outcomes. In other words, many of the outcomes for many of these studies are basically the outcomes that these studies rely on for their claims of success, or that they've proven MUS, or that they claim to show that cognitive behavior therapy works. These trials and studies basically rely almost completely on subjective and self-reported outcomes. That means that you're giving questionnaires to patients, or sometimes to the clinicians, and asking them to answer this, X, Y, Z. Those are inherently subjective. I mean, people respond in ways that they're prompted not just by what's happening, but by their ideas and other notions and bias and things that influence them. And so, so that's challenging, because how do we know that the outcomes are reflecting exactly what's going on? And another problem with these studies is that in studies of medical, pharmaceuticals, we obviously blind people to what they're getting. We blind them to whether they're getting the drug or the placebo. That's the way we can ensure that they don't know and they're not being biased by what they think they're getting. If you think you're getting a drug that's going to help you, you're more likely to say at the end, oh, I feel better. I think that drug is helping me. If you are given something that you're told is a placebo, you may have a placebo effect, possibly, but you're also more likely to say, well, I got the placebo, it shouldn't work, so I'm less likely to feel better. This seems like basic human understanding of how people respond to things. So the problem with this domain of research is that behavioral and psychological interventions like cognitive behavior therapy, or as in for MECFS, graded exercise therapy, are very difficult. You can't really blind them. So patients are always going to know which treatment arm they're in, as are their therapists. So this creates problems for research. So as I said, this issue of unblinded trials or open label trials or studies with subjective outcomes is a huge problem. There's a reason why in medical trials, science decided long ago that we need to use placebos. And that we need to blind patients to whether they're getting the drug or the placebo for self-evident reasons. When you combine unblinded studies and unblinded interventions with subjective outcomes, that particular combination is really fraught with bias. If patients know what treatment they're getting, and in these cases they do, when you ask them at the end, how do you feel, which is essentially what the questionnaires do, of course they're going to want to say, I feel better. Of course, they're going to like the therapist if they like the therapist, and they're going to want to not make the therapist feel bad by saying that they feel worse. If they know that they're not in the arm that was supposed to make them better, they're certainly not and they know that they're going to get later the treatment that they were told is better in the beginning, the intervention, then they're going to be more likely to say, gee, I didn't feel so much better. And they didn't really have a therapist if they're in like a wait list group. So there's no therapist to have any allegiance to want to please. So there's so many psychological reasons why people will be biased, will provide biased responses in this context. And it's almost impossible to disaggregate the bias from the reality. And so these studies are essentially often, from my perspective, uninterpretable. We don't really know what the findings mean. One of the issues, of course, as I said, is that it's challenging to find useful objective measures, which doesn't mean they're impossible. One of the arguments against the argument I'm making is that, well, of course, the treatments are unblinded and there are no objective outcomes of blood tests. So of course we have to rely on this design. And that's a total red herring, and it's a misinterpretation of or people say, well, of course, we only have unblinded studies. Well, of course, but then you have to have objective outcomes. If you have blinded studies, you can have subjective outcomes because then it's not the combination of unblinded with subjective outcomes. So if you actually have a drug trial and you have pharmaceutical and you have a placebo, and then at the end you ask them, how do you feel? And if they don't know which treatment they got, then that's a much more valid response to the actual treatment than it is if they know what treatment they got and whether it was supposed to help. So there are a number of objective outcomes and that have been used in many of these studies, and we'll discuss these a little more. So these are outcomes that tend to assess physical capabilities as opposed to measuring what's going on in the body. So for example, a common test is a 6-minute walking test. So this is done in many major illnesses to see how far people can walk in 6 minutes. A step test for fitness is being like on a step ladder, up and down, and that's a standard test. Actigraphy is like putting a device on your arm or your ankle, like a Fitbit or something that actually calculates or measures how many steps you take. And so patients can wear this for a week or a few days, and it's obviously an objective measure of how much they've moved. Whether people are employed or go back to work or drop out of work before and after treatment, same, are they on social welfare benefits or getting disability benefits before and after, and school attendance. So these are all measures that have been used in these studies. The problem for many of the researchers that I critique is that these studies, for the most part, all these measures have proven to be, even when they do studies that include these measures, the subjective measures say, oh, we feel better, but then you look at the objective measures and there's actually no change. So that's a real problem for the researchers. This is important. This whole domain is important for a number of reasons. I want to mention long COVID now because a lot of these terms now are being applied to people with long COVID, or let me say with the cluster of long COVID symptoms, which totally resemble ME. Okay, so we're talking about the profound fatigue, post-exertional relapse or post-exertional symptom exacerbation, brain fog or cognitive impairments, POTS or other forms of orthostatic intolerance, that cluster of non-specific symptoms that's hard to track to a particular pathophysiological dysfunction, those are common in long COVID as well. And so we're seeing these labels now applied not just to ME/CFS patients, but also to long COVID patients. At the same time, in the UK especially, there's a program called Improving Access to Psychological Therapies that was launched in 2008, which big fanfare, and it was a big effort to save money because of the idea that many people suffer from undiagnosed depression and anxiety disorders, and actually they go to the GP and the GP sees that and can immediately, the IAPT program sort of embeds psychological services in a way with primary care. So patients can be immediately sent over to cognitive behavior therapy most often. So that's fine because basically there are a lot of people with undiagnosed depression and anxiety disorders, and it's great that they can be referred for therapy. Now, I wouldn't necessarily think that the therapy being offered here is adequate or appropriate, but in any event, the concept is okay. When this was expanded into 10 years later to include not just people with undiagnosed depression and anxiety disorders, but to people with long-term conditions, diabetes, cancer, MS, and so on, and with MUS specifically cited. They specifically mentioned chronic fatigue syndrome, irritable bowel syndrome, and other unspecified MUS, which means anything basically that they don't understand. Twitches, tremors, cognitive dysfunction, whatever it is, it can be an MUS otherwise unspecified. And that's what's actually in the IAPT program. It's been claimed as a success, but the data are very, very dodgy, and I'm not going to go into that now. There probably has been, because of changes in the NICE guidelines for chronic fatigue for ME/CFS, which happened last year, and sort of other things that have happened. I'm not sure how robust this program is at the moment, but it's very much embedded, and there's a lot of money spent on it in the UK, and it's all grounded on this nonsense of MUS diagnoses, again, not the initial IAPT, but this expansion. Okay, so This was supposed to be 40 minutes initially. Yesterday I went on for about an hour, so hope you can all bear with me. So these are some of and looking through many of these studies, and along with a colleague of mine, Brian Hughes, who's a psychologist at the National University of Ireland in Galway. These are some of the strategies that we found in terms of this epidemiological sleight of hand. So outcome switching or outcome swapping is absolutely rampant. That means changing outcomes for better outcomes. You decide this was the primary outcome, but now we think that one should be based on what apparently are your results. Or based on a change of heart after you've already written your protocol and started your study. There's a lot of things where the primary outcome has no results, but they claim success based on secondary outcomes, which is kind of dodgy. There's a lot of ignoring or dismissing objective outcomes. They tend not to use objective outcomes anymore in some of these studies because they've always turned out badly for them. And then they have to ignore them or dismiss them as non-objective if they want to report on their studies and claim success. There's a big problem interpreting associations as causal in their favored directions. So in studies, when you find an association or correlation between two things, it's very hard to tell what direction the causal relationship is. An association is by definition, these two things are correlating, but we don't know if one is causing the other or what's exactly happening. So they have a lot of associations that they like to interpret in their favorite direction. I'll just give one classic example. These people tend to find that people who attribute their MECFS to physical causes tend at the end of whatever study or treatment tend to be sicker still than those who did not attribute their illness to physical causes. They interpret that as meaning that the act of interpreting your illness as caused by physical factors is causing you to continue to be sick. The obvious interpretation is that you actually have a physical illness, and that's why you're still sick. So they interpret it backwards. They interpret everything backwards as opposed to the most logical way. And I'll explain one example of that. There's also a lot of misinterpreting statistical significance as clinically significant. So basically, something can be statistically significant in that you do all those statistical tests, and the finding is valid or legitimate, but it may be such a marginal improvement that the finding, even if they've improved, has no clinical significance. So basically, you may still be performing much, much worse than people with other major illnesses, but because it was statistically significant finding, they claim it's a success, even though the finding has essentially no meaning to the person to whom it's applied. There's a lot of writing articles and then a big trial or a big study, and then they get a friendly colleague to write a great commentary about, and they amplify what are really bogus claims of success. University public relations departments are excellent at falsely promoting positively studies that are very bad. That's not what they're supposed to be doing. They're supposed to be having accurate information, but of course they're in the business of hyping everything, and that's what they do. There's a lot of prioritizing within group comparisons in long-term follow-up of trials. So basically, when you do a clinical trial, the interesting part is what's the comparison between the groups. Sometimes these people do a follow-up trial, and at the end, the people who didn't get the intervention are at the same level as the people who did get the intervention. So that's a problem because that's the most factor of interest in a clinical trial. How are they comparing to each other? What these people like to say is, oh, in the group that got the intervention, we already found earlier improvements, and those improvements have been sustained. And they kind of pretend that the fact that the others are now at the same level is kind of somewhat immaterial or doesn't really matter. That's not how you were supposed to report clinical trials. There's a lot of disregard of missing data and dropout rates. People who drop out of trials, you have to sort of start to assume that they are either in worse condition, or the treatment wasn't helpful, or it made them worse, or whatever. That's the sort of standard assumption you're supposed to make. If you sort of ignore them, and the ones who remain in the trial are much, obviously were healthier likely to begin with, then your results will look much better. A reliance on poorly designed control groups or no control group at all. A control group is supposed to match the conditions as well as possible of the intervention group. That means if you're doing, say, a therapeutic intervention, you can't blind them, but you can match, say, the attention that they're getting from the therapist by, having listening sessions or some other way of countering the attention that the patient's getting, which may be what is accounting for these subjective claims of improvement. There's a lot of what I would call authorship review shenanigans. These people peer reviewing each other and publishing each other's journal constantly. They're on the academic boards or advisory boards of the journals where they publish. The editors of the journals are often at the same institution, so they can't go against, or they don't want to go against them, or they won't go against them. This is constantly a problem, and we have a term in this, boys' summer camps in the U.S. called a circle jerk. And I'm not going to, emphasize what that is, but metaphorically in the U.S., it's a well-known term used to describe this kind of insular group where everybody's just kind of patting each other on the back and saying, great, great work. That's exactly what's gone on in this entire domain, and we still see it happening now. And then we have researchers with disclosed or undisclosed conflicts of interest. In particular, links with disability insurers and government agencies that have a real interest in getting people back to work quickly and not having to pay, for long medical treatments and disability for months and years going on. They want people to get back to work quickly. And so, you're supposed to disclose your researchers. And in the PACE trial, as we'll see, they did not. At least they did not to patients, which was the main thing. So I'm going to go over a few just examples of how these work in a few studies, and then I'm going to go into detail in the PACE study, which many of you already are familiar with, but I think some of you probably are not, because it's not just, I think it's some may be. But anyway, if you use that time to go get a sandwich, if you're, go to the bathroom if you're bored with that part. But first, I'm going to talk about a few other studies. So this was one that recently came out of NYU, New York University, and it was kind of shocking, I thought. They basically decided that POTS, which is a form of orthostatic intolerance that frequently accompanies people with ME/CFS or people with long COVID, have orthostatic intolerance, and in some cases POTS. POTS stands for postural orthostatic tachycardia syndrome. Tachycardia just means your heart rate's going very fast. And basically what happens is that people stand up, and for whatever reason, their heart rate increases dramatically when they stand. So they get dizzy, they feel nauseous, they can't stand. I mean, they're too weak to stand, and so they have to lie down again. Again, this is seen frequently in ME/CFS, long COVID. So what the NYU team did was they took patients diagnosed with POTS and patients not diagnosed with POTS. And so they told them both that they were going to soon get a tilt table test. So a tilt table test is how you can diagnose POTS. You put people, strapped into a table, and then you tilt the table upright, and that puts people in an uncomfortable position because they're standing upright. And then you can measure it. You can keep them upright that way because they're strapped to the thing, and you can measure their blood pressure and their heart rate and all these sorts of things. So they found, not surprisingly, that when they told these two groups, one with POTS and one without, that they were going to soon be doing a tilt table test and that the sensations might be unpleasant, the POTS people who already knew how unpleasant this can be had their heart rate increase. So this was considered anticipatory tachycardia. The other people who did not have POTS and so were not familiar with the symptoms and didn't expect any bad symptoms did not have anticipatory tachycardia, which makes a lot of sense. However, their conclusion was therefore that POTS is psychogenic. Again, this is confusing association and causation. The patients had POTS, and that's what caused them to have the anticipatory tachycardia because they were anticipating unpleasant sensations. It's not that the anticipatory tachycardia, then when they're lifted upright, becomes POTS on its own measure. I mean, it makes no sense. They decided that POTS was psychogenic because people who have been diagnosed with POTS, who already know that they feel bad when they're tilted upright, had anxiety about being tilted upright. So that's not fear condition. I mean, yes, it's some fear conditioning. They're used to that, but that's not what's causing their POTS. It's just completely backwards. One of the problems with their analysis was that some of the patients who had POTS actually also had bradycardia when they were told in advance that they were going to have a tilt table test. So bradycardia is the opposite. It's a heart rate slowdown. And so, if you have this theory, then why is anybody having a slower heart rate than normal when you tell them that? So it sort of undermines their claim. So, one of the things I do is I try to respond to these things. So I wrote a letter and I got 8 other experts to sign it. We sent it to the journal. They published it along with some other letters of concern. And of course, the authors gave, what they do, which is a ridiculous response, sort of justifying what they claimed. And the problem with this all is that the study's still out there. The study should not have been published in this fashion because the logic is so ridiculous. And so it's helpful to have a letter or to have letters countering the claims, but much better not to have the bad article in the first place, because now more people will see the article. The article was promoted, I'm sure. And so you have neurologists and other people with this idea that POTS is psychogenic, and they won't see the responses. They won't read the article. They'll just see the headline of the article. So it already creates an idea among clinicians that POTS is psychogenic. So a lot more people probably with POTS might be getting diagnosed as having a psychogenic disorder because of studies like this. Here's another one. The cost of somatization among the working age population in England. This is Birmingham et al. It was done 2010, and it was trying to measure somatization. Again, it's another one of these words: somatization disorder, somatic symptom disorder. Basically, people who are having symptoms that they are unexplained. So they found through the way of calculating that £3 million were spent on somatizing working age patients, and that represented approximately 10% of the total NHS budget on these services for the working age population that year. The budget for the NHS England that year was around £100 billion. So in fact, 3% and that was the total for all NHS expenditures. 3% was actually 3% of the total, and 10% of the total spent on working age population. This seminal study in the field apparently has been mistranslated for going on 10 years by pretty much many of the leading researchers in the field, who continually stated that 10% of the entire NHS budget in NHS England budget that year was spent on these working age patients. In other words, by this sleight of statistics, they tripled the apparent cost of MUS or somatization to the NHS. Now, this statement was misrepeated over and over in papers promoting specifically the need for the Improving Access to Psychological Therapies program for MUS. And there were some people who did this 2 and 3 times, repeated this misinformation. And I'm sure there were other times they did it in public events where I didn't hear them say it. So basically they used this fake information, and I don't think they I think they misinterpreted it, wanting to misinterpret it that way. I don't think actually someone knew that they were doing this. I think they probably are surprised to look so stupid that that's what they did. But as a result, it turns out that the experts in the field are apparently incapable of reading and understanding a pretty clear seminal study in their own domain. It's a little bit shocking. And the fact that this continued for 10 years and that nobody caught it, it is a bit disturbing. I want to say that I have I didn't notice this myself. This was pointed out to me by a source who's very smart and is always sending me, information. And so I kind of then looked at it further, and I had to start writing letters to these journals to get them corrected. But that takes a lot of time to each journal, and then they have to do an investigation and so on and so forth. And there's an example right now. Well, I'll show you one of the ways I tried to get a correction. So the British Journal of General Practice, which is essentially a trade journal for GPs, in 2017 published an article by Professor Sally Graham of Keele University. This repeated this misinformation, and again, it was in the guise of saying, "Oh, this is such a huge problem," But of course, she more than tripled the cost of the problem to the NHS by using this false statistic. I wrote her about it, and she didn't respond. She did this in 2 different places, and I wrote her about it, and she didn't respond to me at all. I wrote her multiple times, and then I wrote to the editor of the journal. One of the blogs that she cited it in suddenly disappeared. They just took it down rather than correcting it. And I will point out that someone had written to her 2 or 3 years ago when it was published that she got the number wrong, and that she just ignored that apparently and didn't change it. So when I complained, then they took that down. But this journal, I had to write to myself. And I heard back from the distinguished Professor Roger Jones of King's College. and emeritus professor even, great. And he decided that, dear Dr. Tuller, if you were certain that a correction would be of any value, the data are a decade old now, please let me have 1 or 2 short sentences that you would like us to publish for consideration. I kind of laughed when I saw this because I thought, wow, what a weird answer. First of all, I wasn't ever aware that in the UK, there's a statute of limitations on data that doesn't need to be corrected if it's more than if it's a decade old. I've never heard that argumentation before. Besides the fact that when I was writing to him, it was already, I think, 3 years ago, was the article was only 2 or 3 years old. So even though the data were 10 years old, they were cited in an article that was just a year or 2 old in order to make a current point about public health policy. So this idea that it's 10 years old is absurd. Secondly, it's not my job to send 1 or 2 short sentences that they might consider publishing. I want them to correct their goddamn paper so people get right information. I don't want to have to send them a letter and do their job for them, which they then will consider publishing or not. Because what they will do is they will publish it and then they won't correct the journal. This happens all the time. So writing letters to journals, I sometimes refuse because I'm not writing about interpretation. I'm writing about a factual mistake, and that's not a question for correspondence. That's a question for editors and researchers to correct their misinformation. So I wrote him back a very long letter, but this was the gist of it, of what I wrote. I wrote this in the letter at the end. I'm asking you to do your job, clean up the mess your journal created when it published a false statement with potentially major public health policy implications. I didn't hear from him, so I had to send him another letter of similar ilk, and finally he made the change. But it shouldn't take that to get a factual correction changed. It shouldn't take someone complaining that the data are 10 years old, or if you think of course would have value to correct a paper. What is an editor saying that if you are certain that a correction would be of any value? This is the most absurd thing I've ever heard. Well, I've heard a lot of absurd things. So it's not the most absurd, but it's pretty absurd in this domain of activity. So here's another one. And then after this, we'll move on to the PACE trial also. So this is a study for dissociative seizures, which is the newer name for what are more standardly called psychogenic non-epileptic seizures. So these are seizures that people have where they don't capture, there's no evidence of epileptiform activity, electrical activity when they do the standard test by putting scalp-based wires and so on. But that doesn't mean they're psychogenic. That's just the interpretation that's given to it by this. I don't think that means they're psychogenic. So, but it's a problem because people have these seizures and it's hard to figure out what's causing them. If you think they're psychogenic, then probably cognitive behavior therapy is a good solution. So for many years, the investigators proposed that, did a pilot study of cognitive behavior therapy for seizure reduction. They made many arguments about why seizure reduction was the core primary outcome for this intervention. After the pilot study, which had not great results, but some marginal results, they decided to do a major study, and they did 368 participants, multi-centers. The intervention was a specific form of cognitive behavior therapy for seizure reduction. So what I love about the CBT they proposed, it's always very specific to the condition, even though it never worked for any of the conditions, or it seems not to work for many of them, I should say. So at 12 months, interestingly, the group that did not get the CBT intervention had greater reduction of their seizures than those who did not. It wasn't just that the findings were statistically insignificant, it was that the non-intervention group had greater reduction. So there was no apparent benefit from the intervention. They had 16 squishy secondary outcomes: depression, anxiety, a lot of what they called the quality of life measures. 9 of them had positive results, but if you actually used the standard adjustment for multiple analyses, which is something you do. If you have 16 secondary outcomes, some of them are going to look good just by chance. So you need to do a statistical maneuver to adjust for that fact. And so of these 16 secondary outcomes, only 5 survived as statistically significant after strict adjustment. They weren't necessarily really clinically significant. They weren't really that big a deal, but based on that, the authors claimed great success. Okay, so the main conclusion of the study, as far as I could tell, was that quality of life measures are more important, and seizure reduction is not the best primary outcome after all. This is an interesting conclusion after you've spent 10 years insisting that seizure reduction should be the core primary outcome. but that's what it did. So King's College London is the institution where the lead author, Trudy Chalder, is based. And they wrote a headline that's really, I think, kind of fraudulent, certainly deceptive. So the headline noted that CBT reduces the impact of dissociative seizures. So, you know, the main headline here is that CBT did not impact seizure frequency. It's the primary outcome is the primary outcome for a reason, because it's the most important outcome. This is a completely inappropriate headline, even though technically, I suppose it's accurate according if you believe their findings, which I essentially don't. Trudy Chalder who's a professor of CBT, so that's obviously the only thing she seems to know about. And she's the senior author, and she wrote, "We now have evidence for the effectiveness of dissociative seizure-specific CBT combined with standardized medical care." Okay, but effectiveness for what? The effectiveness is not for reducing seizures, which was the whole point of the enterprise to begin with. The press release, way near the bottom of the press release, acknowledged that there were, quote, "no clear differences between the groups in seizure reduction," but it did not mention that this was the primary outcome. So is this press release fraudulent? I would say yes, absolutely, in my opinion. And I want to point out here that whenever I say something's fraudulent or something is research misconduct, I'm always adding in my opinion, because I have to make that clear. I'm not the adjudicator of fraudulence. I'm not the adjudicator of research misconduct. I can only state what seems to be, in my professional opinion, as a public health guy. And, you know, something fraudulent means, I think it's deceptive and it's wrong. And I think I would certainly apply that to this press release. So here was a commentary about the codes. This is again along the issue of finding a friendly commentator to say nice things about the study and to amplify the claims that you're making in it. So Dr. Perez, who's a big researcher and leader in functional neurological disorders at Harvard Medical School, he wrote a commentary saying, "In my opinion, CBT remains an effective treatment for dissociative seizures. I have witnessed how some patients with dissociative seizures can benefit greatly from a CBT approach that equips the patient with new psychotherapeutic tools, which in certain individuals can lead to robust and sustained clinical improvement." Okay, Dr. Perez, here's my problem. Your opinion is fine, but the reason we do clinical trials is because we don't want to just rely on clinical opinion. Clinical opinion can be as biased as any other opinion, and we do trials to actually find out facts, not opinion. You have witnessed some patients in certain individuals and so on. That's really not valid evidence. That's anecdotal evidence from your perspective as a clinician. That's very nice, but that's not the basis on which we make health policy. We make health policy based on findings from studies and clinical trials. And this clinical trial, unfortunately for you and your colleagues and for the authors, found that those in the non-treatment group did better when it comes to seizure reduction. So again, he raises the question, a major question is whether seizure frequency should be the preferred primary outcome measure in clinical trials for dissociative seizures. I would say that's only a major question for the disappointed researchers whose theory turned out to be bogus, or whose understanding of the case turned out to be somewhat flawed, since it did not lead to seizure reduction. So the only major question is not to other people, it's just to you people who did this study, that you now want to have a different primary outcome. So I would call this, this is not outcome swapping because they reported the outcomes as is. It's kind of a post hoc outcome swapping. I've never quite seen, where they decide after the fact that they used the wrong primary outcome. So he suggests other therapeutic interventions should be tried in patients and so on and so forth, even though there's no evidence for those cases either. And just as there's now no evidence that CBT helps seizure reduction or no evidence from this particular trial, I should say. Other trials have had some other findings. From this particular trial, which was supposedly the definitive trial of this intervention for this condition, we have the answer. So here's one more just quick example. This is a study of chronic fatigue syndrome. Also, senior author was the same, Trudy Chalder from King's College. So I mentioned how ignoring dropout rates is one factor. If you look at the chart here, I'm just going to talk about this one chart. You see at baseline, they started out with 508 participants, and at follow-up, they only had 316. Now, they acknowledge in the study that those who dropped out and did not provide data at the end were sicker than those who were sicker at baseline than those who ended up providing data at the end. It doesn't take a genius to figure out that if you lump everybody together in the first group, but then you only provide the data for those who actually were better off in the second group, you're going to sort of artificially inflate the apparent benefits of the treatment, because you're including the worst cases in the initial, but they're all removed from the second batch. So this comparison should really be between the 316 who entered and the comparison we should be able to see the data for the 316 at baseline, not just the aggregate data for the 508. We want to see what happened to the 316 before and after, not this mishmash of everybody and then just those who remained in the study. This is very, very deceptive, and I don't understand why something like this is not caught in peer review. Again, we wrote a letter, a colleague, Brian Hughes, and I protested this study and wrote a letter, and there's many other problems with it, but this was one of the aspects that we pointed out. So let's move on to MECFS, and then we'll talk about the PACE trial for a bit. How am I doing on time?
As you like.
Okay.
You're 50 minutes in.
I'm 15 minutes in?
50.
50. Oh, okay. Okay. This is taking longer than yesterday. Okay. So basically, MECFS, for whatever many years, it's been treated as psychosomatic, and basically the concept that arising largely out of the UK, but was also became popular around the world, was that people had an initial infection, like a viral illness, then they would get better, but they would have been in bed for a month or whatever, and then they start to do something and they're very deconditioned, meaning they're out of shape because they've been sedentary, which happens. Then they feel bad because they do something and they're physically weak, so they feel bad. But because they've heard about an illness called ME, or because they decide that they're still sick, they think, oh, I must still have an illness, and then they go back to bed, and then they get even worse. And so they think there's what they call a vicious cycle of deconditioning and then false illness beliefs, the belief that you have an ongoing organic illness and that you have to stay sedentary, and then you get more depressed, and then you get more fatigued, and then you get sort of your sleeping disorders, and this is all a vicious cycle. And you need to intervene in one of two ways, either through a graded exercise therapy program in order to get you to increase prove that you can increase your activity gradually and get reconditioned, and that if you feel symptoms, you ignore them because you push through them, because that's just the deconditioning acting up and it's nothing permanent. Or you get cognitive behavior therapy to help you alleviate you of your dysfunctional beliefs or unhelpful cognitions, or whatever they're calling them, about the fact that you have an organic illness that makes you sick when you do something. Now, the problem with this is that we now know the Institute of Medicine and the National Institutes of Health, both in 2015, released long reports that were based on reviews of many, many thousands of studies. So the Institute of Medicine, which is now called the Academy of Medicine in the US, it's kind of like, it's an independent body that the government does commission studies to. So they declare that MECFS is a serious, chronic, complex, and multi-system disease that frequently and dramatically limits the activities of affected patients. It didn't discuss the PACE trial specifically, but it really implicitly rejected the idea. It made it clear that this is not a psychiatric illness, it's not depressive or anxiety disorder, it's not a functional disorder or a somatization disorder, and it's not caused by deconditioning, it's not caused by false illness beliefs. It pointed out that the main symptom is not fatigue per se, or, oh, I'm so tired, but what it called exertion intolerance, and what's generally been called post-exertional malaise, or PEM. This is a symptom that what happens is that people exert a minimal amount of energy and have a completely disproportionate relapse, or completely disproportionate impact, and they become sort of paralytically exhausted, not just kind of vaguely fatigued like a Victorian, fainting spell. There's something about, we don't really know why this is happening. There's a lot of theories about mitochondrial dysfunction, not producing enough, broken in the energy ATP cycle to produce energy in the cellular level, all sorts of, and that's what's being investigated now in MECFS, as well as in now long COVID, because in long COVID, this symptom is often called post-exertional symptom exacerbation, because it's not just fatigue that gets worse or the exhaustion, it exacerbates all the symptoms, the brain fog, sleep disorders, and everything gets disrupted after a minimal amount of exertion. So that's the core symptom, not fatigue. And in that sense, increasing your activity on a kind of set schedule or ignoring the symptoms of post-exertional malaise is really contraindicated. I was not counterintuitive, but contraindicated as a treatment. The other problem is that, and we talked about this in terms of who are the patients. When you diagnose something by symptoms, you're always going to get a group with some people who don't have the disorder. So you want to get a specific set of criteria as possible. The Oxford criteria was developed, obviously, at Oxford and in the early 90s, and it just calls for 6 months of unexplained fatigue is the criteria. And the reason why that's a problem is because fatigue is one of the most common symptoms which people present to doctors, or people present as problematic. And there's a bazillion reasons for it. It's a cause of many conditions can cause it. Depression can cause it. Anxiety can cause it. So if you just have 6 months of unexplained fatigue as your criterion, you're going to have a lot of people who don't have ME/CFS and who just have some sort of, kind of fatigue that we don't know why. It might be depression or anxiety. And in that case, cognitive behavior therapy or graded exercise therapy is going to possibly work because those are known treatments for depression or anxiety. And so if you get this kind of heterogeneous group, you're going to have lots of problems in interpreting your data. And so if you don't actually believe that there's much of a thing called ME/CFS and that all these people are really just suffering from, some sort of weird fatigue, it doesn't really matter whether you make that distinction. But if you actually believe that ME/CFS is a clinical entity, even though it's hard to define, then this is a huge problem. So anyway, the National Institutes of Health in the US suggested that this criterion, which was the basis of many studies into chronic fatigue syndrome, that it should be retired. So PACE, now we come to the PACE study. I called it a piece of crap, and it's also been called by Professor Sir Simon Wesley at King's College London a thing of beauty. He's, I think, a bit deluded if he actually believes that. I don't know if he still believes that, but it's really a delusional belief because it is really a thing of ugliness, and it's a thing of harm in terms of what it's done to patients. It was the first results were published in the Lancet in 2011. It was launched in 2005. And it was a £5 million trial that was funded by the Medical Research Council and a Scottish agency, and also partly by the Department for Work and Pensions, which is interesting because they obviously hoped it would get people back to work and would help them not have to receive long-term disability or whatever. So this was considered and presented by the authors, investigators, as the definitive study of CBT and GET. They have since sort of backed away from that claim. So it was open label, unblinded with subjective outcomes. They had objective outcomes, but all those measures failed to show any success or showed the same success as the subjective outcomes. So they basically dismissed them as irrelevant and kind of didn't really highlight them in their findings as they reported their findings. And they dribbled out these findings sort of across several papers so they wouldn't have to collectively put them all together and say, gee, all our objective outcomes failed. I wonder why. That was my interpretation of why they did that. I don't know that's why they did that, but I'm assuming that's why they did. They used the Oxford criteria in conflating chronic fatigue and ME, so we have some questions about who the patient population was. 641 participants, a very large study. There were 4 trial arms: cognitive behavior therapy, graded exercise therapy, something called adaptive pacing therapy, which we don't really need to go into, and specialized medical care, which just basically means seeing your doctor a couple of times or whatever. The principal investigators were Peter White at Queen Mary University of London, Michael Sharp at Oxford, and Trudy Tralder, previously named already. She has to be one of the most incompetent researchers I've seen. Every trial she does seems to be fraught with problems, and the other people as well, in many cases. It's based on this unproven theory that all the symptoms are due to deconditioning because of patients' dysfunctional cognitions about their illness or unhelpful beliefs. They claim success. They claim that 60% improved and 22% recovered with these treatments. Okay. So what are some experts responding to PACE? In the course of reporting my 15,000 word opus on this, I was able, I think, to get, what was helpful was that I was able to get negative comment on the study from people who had nothing to do with it, which normally doesn't happen because researchers don't like to just trash other people's work for no reason if they're not involved with it. But in this case, I think people were so shocked by the terrible nature of this work that it was very easy for them to criticize it. So Bruce Levin, a very well, he's emeritus now, a biostatistician at Columbia, called it the height of clinical trial amateurism. Ron Davis is a well-known geneticist at Stanford, whose son is actually severely ill with ME/CFS, wrote, I'm shocked that the Lancet published it. Professor Jonathan Edwards, my friend and colleague, who's an emeritus at University College London and has been very effective in trying to counter the PACE influence. He's called it a massive incomprehensibility. I called it a piece of crap. Carol Monaghan, who's an MP, Scottish MP, she held a couple of hearings and called it one of the biggest medical scandals of the 21st century. Simon Wesley, as I've said, called it a thing of beauty. Queen Mary University of London, when I first started reporting on it, sent me sort of, I thought, sent threatening messages, I thought, claiming that I was causing online internet abuse of the researchers and my work was causing online abuse and reputational damage. I responded that, of course, I opposed to any online abuse, but I certainly didn't apologize if my work caused reputational damage because that was what I hoped. That was an aspiration of mine to cause reputational damage to the work and presumably to the researchers because they continue to defend the work. So here are some reasons for concern. I'll go through each of these, but I'll try to do it relatively quickly. Outcome switching without proper justification, lack of legitimate informed consent, biasing participants by publishing trial testimonials during the trial and by issuing positive messaging about recovery from CBT.
That's a good one.
These things are unbelievable, some of these. Rejection of objective outcomes is not objective after all. The study design, as I've said, the unblinded and subjective outcomes and the use of the Oxford criteria. These previous four things, from my perspective, are all potential reasons for possible research misconduct or possible retraction. The last one, it's just a bad study design, but it's accepted study design, and the use of the Oxford criteria, that was a published criteria, set of criteria, so it's hard to say that that should be retracted because of that. It's just terrible science. So this is sort of the most challenging thing to explain because it is so bizarre. And they did great deal of outcome swapping in the PACE trial. But the most shocking one was in one of their primary outcomes and one of their criteria for entry. Physical function on a scale, on a questionnaire called the SF-36, which goes from 0 to 100. So if you score 100, you're in perfect condition. Most people, even with some disabilities, might score 80 or 85. That's kind of normal. People tend to score on the higher range of this. If you score, so for this trial, they required patients to have a score, and the questions were like, can you walk the stairs? Can you lift something? They're all questions that sort of are trying to assess your physical function. So get into the trial, you had to score 65 or less on this questionnaire. That is quite disabled, actually. They wrote a protocol, like a big trial will do. They write a trial protocol, and that's the basis for getting money and funding and approval to do the study. So in their protocol, they wrote that a score on the SF-36 of 85 and above would indicate recovery for physical function. So they published two papers with these data. One was the first Lancet paper, and the second was a paper in the Journal of Psychological Medicine 2 years later. And in the Lancet, they decided that, they decided that recovery or meeting the threshold for physical function, they called it a normal range, and I'm not going to go into that, but that's a completely fraudulent claim because it's not a normal range. They did the wrong statistical test for that. And as I've documented, they knew it was the wrong statistical test, and they didn't make any indication of this in this paper. I consider that to be really research misconduct. But in any event, they used the phrase recovery. This was recovery for physical function. You had to have a score of 60. So let's be clear. You could enter the trial at 65, being severely disabled, but you could be recovered for physical function if you got worse and scored 60. Very interesting. It turns out that 13% of the participants were already recovered on physical function at entry. How did that happen? Of course, this was a post hoc change. They made this change long after they started the trial. So that's why they were in the trial, because they didn't realize at the beginning they were going to make this big change. But it makes no sense that they were in the trial in the first place if they were going to make this revision. And the other thing is that you have to tell people this. You can't have people recovered on a measure in your study at baseline and not let people know. First of all, the paper would never have been published had they disclosed that. Second of all, readers need to know this if you're going to do that. The other thing is that this wasn't clear from the trial. From the way they reported it, it was clear that it was possible people could get worse and be recovered. We didn't actually know what the data were until a patient got it through the free move information request, that we found out that 13% of the participants actually were within the normal range. The other major primary outcome was for fatigue, and this exact same thing happened. They lowered the outcome threshold for fatigue to below the entry level for disability, so people could be could get worse on the fatigue questionnaire and still be counted as recovered for fatigue. And in fact, some people were recovered, a few recovered for both fatigue and physical function when they entered the trial. So why were they in the trial? So there was rampant outcome switching in PACE, and there's multiple examples of this. Every single time they did this, it had the effect of weakening the measures. So they were able to get better results by weakening their measures. So what were their responses to this claim, these charges? And these are responses they made in response to my long investigation, but also responses they made other times when subsequent efforts of patients have made similar claims, because there's been an ongoing debate about this. We changed outcome measures before seeing the results, so they were pre-specified. This is really nonsense. In an unblinded study, that would be true if it was a blinded study and that there were objective outcomes, perhaps, or if it was blinded, because you wouldn't know. But in an unblinded study with subjective outcomes, you have to be not very intelligent to not realize what way your results are trending. It's pretty obvious if you want to get a sense of it, because you know what groups people are in and you know how they're responding. So it doesn't matter that you didn't see the results formally, you knew what was happening, and that's why you changed the results. We decided our original measures were too stringent. This is totally ridiculous. Why did you write a protocol? The reason you write a protocol is to think these things through beforehand. You are not allowed to make changes because you decide later that what you decided previously was too stringent. And what does too stringent mean? You studied the field, you chose the measures that you thought were best, and that's what you got approval based on. Okay, it doesn't matter that people were recovered on key variables because we had other recovery measures as well. I call this a response from outer space. I don't even know how to respond. You can't be recovered on any variables. What they're referring to is that they had 4 recovery thresholds. So they had 4 measures on which you had to be recovered for each to be considered to be recovered overall in the trial. But that's irrelevant. Nobody can be recovered on any measure at the beginning of the trial. It doesn't matter that you had other measures. It's ridiculous. Revised measures show CBT, the way they revised, they said the revised way that they assess things showed that these had the best average results. This is also stupid. Their initial measures their initial outcome measures were rates. What percentage of people got better and what percentage of people got worse. That's kind of what patients and doctors want to know. If you have an average, that tells you something. It's useful in certain ways, but you have no idea from the average how many people got better and how many people got worse, because there are always going to be outliers who got much worse or outliers who got much better. Just as one example, if you put me and Bill Gates in a group together and then you average our assets, I will look like I had billions in assets, but I don't. He does. But if you average it, it will look like we're both, pretty rich, okay? That's what they want to do. They change from percentages to rates, to averages, and that's not really cool. They could have provided both, but they didn't. So then they said, a lot of people, once data were released by a court order, there were reanalyses done, and to show what would have happened had they stuck to their original outcome measures. And I was a co-author, just for disclosure, I was a co-author, a minor co-author on a paper that reanalyzed all the PACE results, the main PACE results. And they're complaining that people tweaked their outcome measures to make the results look worse. And that's, again, backwards. They tweaked their measures to make them look better. Those people who reanalyzing it according to their protocol measures were untweaking what they tweaked without any justification. So PACE did not obtain informed consent. They obviously had consent forms, but here's what happened. In the trial protocol, you promised to follow this, ethics regulation and the Medical Research Council regulation and this one or that one. And some people often promise to adhere to the Declaration of Helsinki. So the Declaration of Helsinki was an international human rights document developed after World War II to prevent human atrocities or to kind of try to prevent human atrocities in research the way as happened in Nazi Germany. And it's pretty clear, and so it's gone through various iterations over the years. And in 2000, when in the early 2000s, when the PACE authors did their consent forms, the Declaration of Helsinki was very, very explicit on how to obtain informed consent from participants. Researchers must tell prospective participants about any possible conflicts of interest and any institutional affiliations. So that's very broad, any possible conflicts of interest. It doesn't mean definitive conflicts of interest. It's anything that someone might consider to be a conflict of interest, as well as any institutional affiliation. So if you have an institutional affiliation, like with an insurance company, you need to declare it. So the PACE PIs, principal investigators, they've advised disability insurers that rehabilitative therapies like CBT and GET are indicated for ME/CFS claimants. They've argued in some cases that nobody should get benefits if they haven't been through these treatments. And so on and so forth. And, that's been part of their work. They obviously did not include these disclosures in their consent forms. How did they answer this? We told the journals about our possible conflicts of interest. Okay, this is a complete non-response. I don't think journal editors were tortured in Nazi Germany. The Declaration of Helsinki has nothing to do with journal editors. It has to do with participants in research. So the fact that you told the journals about your possible conflicts of interest, which is fine, and something you had to do, so you don't get credit for that, that's what you have to do, but you didn't tell the patients, and you didn't tell the participants what you promised to do. Nobody forced these people to promise to adhere to the Declaration of Helsinki. That was their choice. Having done that, they have no justification for omitting, a core plank in it and deciding not to include that. I think they probably didn't even know that plank was in it, perhaps. I don't think they even thought about it. I don't think that necessarily deliberately didn't do this, but they promised to follow this and they didn't follow it. And they don't have actually informed consent for anyone in their study. Their other answer was insurance companies were not involved in the study. This is ridiculous, again, a non-response. It doesn't matter. That's not the point. You were involved in the study and you have links to insurance companies. That's the point. There are many ways to have conflicts of interest other than having an outside company fund your research, okay? And so this is a non-response. Then they said only 3 of the 19 investigators did work for insurance companies. First of all, this wasn't true because it was 4 of them, according to their own disclosures to journals. And secondly, again, it's irrelevant. Then you tell about those 3 who had links with insurance companies to participants. I mean, these are all complete non-responses, as are their responses to all the concerns raised by patients. Then they did something quite extraordinary. During the trial in December 2008, they published a number of 3 or 4, I think, newsletters during the trial, trying to, get people excited and so on and whatever. I guess that's okay. But in this particular newsletter, they published testimonials from participants who had finished the trial. So this is quite extraordinary because during a trial, you're not really supposed to be publishing glowing testimonials from patients who were in it. It's just a weird thing to do. These were the kinds of comments that the therapy was excellent and very helpful. Being included in this trial has helped me tremendously. The treatment is now a way of life for me. I found the treatment extremely useful. I am so happy that this treatment trial has greatly changed my sleeping. They also included something about NICE, the National Institute for Health and Care Excellence, which develops clinical guidelines in the UK that are widely regarded. In 2007, NICE developed a clinical guidance for ME, for what it called CFS-ME, that recommended CBT and GET. This committee that developed this was populated by all the same people that and colleagues of the people that I've been criticizing, so it's not surprising that it came up this way because they're part of the CBT, GET ideological brigades, as I call them, and I think it's kind of a cult-like situation because there's not really evidence to support their claims. But anyway, in their newsletter, they wrote that it recommended these 2 treatments based on the best available evidence. So based on the best available evidence is the quote from the newsletter that they sent to patients. So when I pointed this out, the responses to the newsletter situation were the treatment arms were not mentioned in testimonial, so there could have been no bias. As I said, it's hard to know how to respond to such a claim. They mentioned treatment, they mentioned therapy. It's actually not allowed to bias anybody in your study, even if you're biasing everybody in the same direction. You can't bias people this way. How can you say there could have been no bias? There's bias overall to think positively about the trial. You're not supposed to do that. Maybe people hated the trial and they don't want to think positively about it. You're not supposed to tell them how great the trial is. That's not your job as the investigator. The article about NICE in the newsletter mentioned not the CBT, but activity management, which was the third treatment offered in PACE. So the statement in the newsletter could not have induced bias. Okay, activity management is not mentioned in the PACE trial. They may think activity management, which they also mentioned in the newsletter, is the same as adaptive pacing therapy, but it's not. It has two different names, so how can it be the same thing? It's ridiculous. It's a ridiculous statement. I ran this by a biostats colleague at Berkeley, and he had a funny response. I showed him the newsletter, and he just kind of stared at it like, what? What? He was like, they participants saw this during the trial? And he kind of scratched his head. He said, well, I guess there's not actually an official prohibition against sending out testimonials or against giving, having participants give glowing testimonials. He said, but that's because it never occurred to anybody that anybody would try to pull such a stunt. So, this is really mind-boggling. I don't think anybody had ever seen anything like this that I had talked to in my experience among my colleagues at Berkeley. And again, I'm not an epidemiologist and I'm not a biostatistics person, so I sort of vet all my claims with experts. I have very broad knowledge of public health, and that's the basis on which I'm making these observations. So for their objective findings, and I'm coming close to the end here, they had 4 objective outcomes. Some of these I mentioned earlier: the 6-minute walking test, a step test, employment, whether people were employed or not, and receipt of benefits, before and after the trial. The results for all of these were either null results, so there was no difference between the groups, or they had marginal results that were clinically meaningless. And the one case where that was for the graded exercise therapy group. They did marginally better number of meters in the walking test than they had previously, but they still were so much worse off than people with, awaiting lung transplantation or with congestive heart failure. I mean, they really were still doing very, very poorly compared to other illnesses. But the PACE team, that didn't matter to the PACE team. They decided that their own objective measures that they had selected and touted as their objective measures were not in fact objective. Why wasn't the 6-minute walking test objective? Well, we did it differently. We were worried about their condition, so we didn't encourage them to keep walking as much as we might have had they had another condition. And they also said, well, we only had 10 meters for them to walk in, and usually the test is done in 30 meters, so they have to turn around more often. Well, that's your own problem for doing it differently, but that's not a good excuse for dismissing it as non-objective. They also said that other factors, some people who are well decide not to work, and other people who, or can't find a job, or there's things about the economic situation, and they sort of insisted that other factors influence employment and benefits. Well, of course that's true, but again, nobody forced you to cite these measures, and it doesn't give you the right to just ignore the fact that more people were on benefits at the end than before, and that nobody got back to work. That there was no benefit to the people, there was no overall getting back to work. The results were washed out. So, if subjective and objective outcomes conflict, which is clear in this case and in other studies of CBT and GET for this illness, honest researchers question their assumptions. In other words, you wonder whether something's going wrong or whether your subjective outcomes are really correct, while those without integrity dismiss the bad results of the objective outcomes as flawed and just rely on the subjective outcomes. It's really disgraceful what they did here. So as PACE an example of research misconduct. Here's the Medical Research Council defines research misconduct as misrepresentation of data, for example, suppression of relevant findings and or data, or knowingly, recklessly, or by gross negligence presenting a flawed interpretation of data. I would say that this applies to a T to the PACE trial. A misrepresentation of data, certainly not disclosing that participants were recovered at baseline on key measures, and so on. Misrepresentation of interest, including failure to declare material interest, either of the researcher or of the funders of the research. Well, I think that is research misconduct because they violated their promise to observe the Declaration of Helsinki. In 2005, it probably would not have been a violation of MRC or considered a violation of MRC guidelines and other guidelines not to disclose their conflict or potential conflicts to participants. It might have been depending, but it was a more squishy area. But certainly violating the Declaration of Helsinki, your own promise, is certainly, I consider it research misconduct. Here's a definition from the National Institutes of Health, which is essentially the same. Here are my conclusions about PACE. They can't be taken at face value. It proved that the defeatments in the definitive trial didn't work. The data manipulations, lack of informed consent, and other issues could lead to the conclusion that this is research misconduct, as I think it is, according to standard definitions. Basically, the PACE authors have accused patients of being anti-science, climate change deniers, and so on. They're the anti-science crowd. They're the climate change denier types, not patients. Patients have been correct from the start, or many patients, I should say. I mean, some patients haven't, but many of the patients who analyzed this, who I relied on to a large extent in the beginning and ongoing because they're so brilliant, they're the right ones. They're the science crowd, not the PACE authors. So the response to this controversy, the CDC removed CBT-GET from its recommendations for MECFS in 2017. NICE itself last year went through a whole process for 3 years and published new guidelines in 2001, which rates the quality of evidence from PACE and other studies as very low or just merely low. Most of it was very low. It reversed the recommendation for CBT and GET, said there was no evidence for these as curative treatments. I was part of a reanalysis where we redid the PACE trial according to the own protocol. Instead of 60% improvement, they had 20% improvement according to their own measures, and 10% of improvement was in the comparison groups. So that 10% marginal improvement rate is very squishy and is very clear that that easily could result from the bias inherent in the study design. And in terms of recovery, the recovery from 22, it turned out that there was zero recovery. All the groups had a recovery rate, again, by their measures, so I don't consider that recovery, but by their standard definition of recovery, all the groups had a single-digit recovery rate, and there were no statistically significant differences between the groups. Berkeley has found the best use for PACE, I think, as a pedagogical tool in doctoral seminars, as a case study of terrible research. But I consider the PACE trial discredited. I was delighted to see The Guardian had an article by a friend of mine, a long COVID patient, Fiona Lowenstein, where she wrote that something I think she wrote, PACE trial has been debunked, and she linked to my study, my investigation, and that really delighted me. They, of course, do not consider it debunked. The PACE authors and their colleagues and their cronies and their cabal, their fellow brigadiers in the ideological brigades, in the UK, Germany, Denmark, Norway, northern Scandinavian countries, and northern European countries seem, for some reason, many experts there seem wedded to this false paradigm of MUS and CFS and so on. And so they're still pushing forward. And we have a situation in Germany now where there's a report promoting these strategies that sort of has minimized the problems with PACE. And PACE is only one of multiple CBT trials for MUS. Conditions that fall under MUS or conditions that fall in, say, FND or in these other domains. We've already talked about psychogenic non-epileptic seizures, the CODES trial. I've written a lot about another study by many of the same people for irritable bowel syndrome. Also really poorly reported, very deceptive in the way they've done their reporting and promoted the results. There's a lot of promotion of cognitive behavior therapy and exercise for long COVID. Let me say that cognitive behavior therapy, many people with long COVID or with any chronic illness, of course, have anxiety, depression, psychological issues. Cognitive behavior therapy may be helpful for them. So one of the arguments against the things I'm saying is, well, we suggest it for cancer patients or MS patients, and that's true. But of course, nobody's suggesting that cancer-specific CBT is going to cure you of cancer, or MS-specific CBT is going to alleviate your MS. Nobody promotes it that way. That's how they promote it for these other conditions. They're promoted as a curative treatment, not a supportive therapy to help people cope with the terrible situations they're in. So of course, there's also CBT for every other kind of MUS you might think of. It's all a big, whatever, morass. So that's my talk. So I feel like we've made a lot of progress in the ME/CFS domain. I feel like long COVID is helping shed light on this sort of post-viral phenomenon, the phenomenon of post-viral illness that we're seeing on a worldwide basis. Unfortunately, to many of these people, they see the worldwide phenomenon of long COVID as a case of mass hysteria, of psychosocial strain. People are too depressed and too anxious. That's why they're having all these cognitive problems. That's why all these doctors can't work. It's nothing organic. If they talk about it being organic, they're just playing into the desiccated mind-body dualism and so on and so forth. So all the while, they can ignore the very terrible pathophysiological issues that people are having in terms of not being able to function very well. So I want to thank, so this is still an ongoing situation. So that's why I'm still working on it. These are my thanks. I can't even begin to thank patients enough. They're sharing their stories with me and sharing their knowledge and understanding and allowing me to make mistakes, especially early on, and being supportive of my work. My colleague, Professor Raccaniello at Columbia, who basically trusted my reporting. If I'd been mistaken, we could have both been in big trouble. UC Berkeley, my colleagues have completely given me value my academic freedom when the University of Bristol sent bizarre messages complaining to the Berkeley chancellor about my behavior. Berkeley thought, well, we don't know what they're talking about. Keep working. Center for Global Public Health at the School of Public Health at Berkeley is my institutional home there, and they've been great to me. And anyway, I've had a lot of colleagues at Berkeley who've given me a lot of support at the School of Public Health. That's been very important to me because I've taken on a lot of people who hate me, especially in the UK. And a lot of people have signed my open letters, and that's really been important because I think it's really helped me help push forward things, to have not just me out there yelling, but to have people signing letters. So you have 100 experts signing a letter to the Lancet saying the PACE trial stinks. I think that's very important. And if you like my work, this is my current October crowdfunding campaign. The money goes directly to Berkeley, not to me. If you're US or Canadian taxpayers, I understand it's tax deductible. And that's it. So thank you very much for bearing with me for a long time.
Wonderful. Thanks everybody who came. Apologies that we don't have time for a discussion after this impromptu talk, but thank you very much, and hopefully this time I will get the video successfully posted soon. And feel very welcome to come to any other hidden epidemic sessions you should be interested. But one thing you might like is tomorrow at 3:30 UK time, David is giving another talk with the wonderful Robin Gorner that's going to be on activism and advocacy in public health.
And one thing I want to say that my email is there on my email. Maybe you didn't see my email is davetuller@berkeley.edu. So I'm very easy to find. So feel free to touch base if you want to say something or whatever. I'm always happy to hear from people.
Okay, so might see some of you tomorrow online, 3:30 for activism and advocacy in public health, which will be long COVID, probably some ME/CFS, HIV. Yeah, the fight to make these things visible. And I think that is essentially us done.
Okay, thanks.